Good afternoon, dear friends. I hope you've had a very happy and satisfying lunch. And back to some more academics. We have a live case from the National Heart Centre, Singapore, a calcified lesion. My name is Dr. Ashok Seth, and with me is Dr. Ho. We have a tremendous panel from all across the world, and you're going to have some great academic feast after your sumptuous lunch. Chat moderator is Dr. Benji Lim. Please do not forget to scan the QR code and then put in your questions, put in your chat, clarify, and we make all the efforts to answer your questions. With these words, I think we're going to go on to the case presentation and discuss the case.
Are we ready to go to Heart Center? So the focus for today's session is calcified lesion, and the operators is Professor KK Yeo and Mohammed bin Idu. Can you hear us, KK?
Can turn on the TV on the, not yet, almost.
TV?
The TV sound.
TV sound?
Yeah. No, just now I asked them to turn off the sound, so normally there'll be some background noise when the chairs are shook, right?
Yeah, we can hear you, KK.
We can hear you very well.
Good. Oh, good. Hi, Hee-Hua.
Hi.
Okay, let's get the 1-2 fiber.
Do you want to start on the case history, KK? Because we have...
You all can hear us now. We are live, is it? Sorry, we didn't know that.
Yes.
Okay, great. Thanks. Hi, good afternoon, everyone. Welcome to Sing Live 2023. My name is KK Yeo from the National Heart Centre, Singapore. Today with me is Dr. Mohammed Idu and Sister Tina, as well as the rest of the team here. We're going to bring a case of calcified left main, and I'll let Dr. Mohammed here introduce the case.
Okay. So our patient is a 74-year-old lady with the comorbidities of hypertension, dyslipidemia, diabetes on insulin, and end-stage renal failure with a previous history of renal cell carcinoma with operation done. She also has hepatitis B. Next slide. Her cardiac history include atrial fibrillation, and she actually had presented with breathlessness on exertion in 2019 as well as 2021. However, previous echo and MIB were negative for ischemia and with normal EF. However, late last year in November, she actually presented with dialysis, chest pain, and hypertension. And echo then did show normal EF, but because of the symptoms, she underwent coronary angiography, which showed a severe calcified left main and TVD with a right RCA CTO. She was actually reviewed by the cardiothoracic surgeons, who considered her to be a poor candidate for CABG in view of her comorbidities, and she underwent PCI instead. So the RCA CTO was done on end November, and two stents, 3.5 and 3.0 stents were implanted on the right. Next slide. This is a baseline ECG, AF. Next slide. Baseline labs, hemoglobin is 10.8. LDL is 2.48, and HbA1c is 6.1, which is fairly reasonable control except for the LDL. These are her current medications. She's on aspirin and Plavix since the last PCI. She's also on insulin, and she's on Etova 40 mg. Next slide. So this is actually the angiography on the left. It shows actually a distal left main bifurcation 111 lesion with the titus at the ostial circumflex, and with what appears to be a nodule right at that distal left main to circumflex region. It looks like a mixed dominance. There's also a moderate mid-LED lesion as well as a tight distal circumflex lesion.
Cool. So,
okay, next slide.
Next slide.
Next slide. Yep. Cool. So some other views of the very tight left main bifurcation. It's a very large left main, and actually the circumflex itself also looks large. So we'll need to consider the vessel diameters and our strategy for this case. Next slide. Okay. This is the right after the PCI. So the last stents, this is after the previous PCI. Next slide.
Safe.
So her syntax score is 52, Euroscore 2.6. Next slide. So in summary, this is a 75-year-old lady with hypertension, dyslipidemia, diabetes on insulin, and end-stage renal failure on dialysis with AF, and presented with intradialysis chest pain TVD, RCA-CTO fixed, and now the problem is the left main bifurcation lesions. Yeah, I present to pass over to Dr. Yeo to talk about a strategy for this case.
Yeah, so this case is I think you all can see from the pictures that I'm showing now that the right, after a very nice result, the CTO is still nicely patent. And this is the left again. I think even before the contrast goes in, you can appreciate the heavy calcification. There is a distal circ disease, which turns out to be a bit more of a trouble than we anticipated. And this is the, sorry, I did this to illustrate the calcium with just a cine still frame. Let me just show the last picture before the panel discusses, and then we'll tell you where we are shortly. So this is the...
Can I interrupt you?
Yeah.
Just wanted 3-4 minutes for the panel to say what they would like to do before you tell us what you'd like to do.
Yes, very good. Thanks, Ashok.
And so could I actually ask Dr. Zhang, you have this in your lab. What would be your first thoughts? And we've already committed to a PCI. What are you thinking of?
Yeah, I think this case is a very calcified lesion. So I think the guiding catheter is very important for this therapy. So I will choose XB7 French XBX guiding catheter. So this kind of lesion, I think it is most effective. The therapy is IVL, but the problem is the osteal circumflex is much difficult to pass the IVL balloon. So maybe I will try the wire the circumflex, and according to the feedback, the resistance is very high or not. If resistance is very big, I will multiply the 8.
I'm just going to interrupt you here because I'm now going to ask very specific questions in the interest of time. So, Sonaria, Rota, IVL.
Yep. I think this is a case where in the heart team, we as a surgeon will be happy to have this case from the surgeon. Distal runoff is very big, but again, I think it's not good case for surgery. So the task for us is to have a good imaging and decide it.
So first just answer, imaging will come to.
Yep.
What would you use in this case? What is the adjunctive devices you'd like to use in this case? You've got this case in front of you.
Well, I mean, if I have Rota, then I will use Rota. If I don't have Rota, then I will use everything to
What about
prepare.
you have IVL and Rota?
I don't have experience IVL at that time. So,
so you'd use, your first attempt would be Rota. Pratap, I'm now going to talk imaging. OCT or IVUS?
IVUS. There is no,
or none?
There is no question IVUS is must because this patient have an end-stage renal disease, so there is no question of OCT in this case.
Right, so OCT.
IVUS, sir, IVUS.
IVUS, sir. Agree, I think everybody agrees with that, thanks. Richard, hemodynamic support or no hemodynamic support? I mean, and what, do we really need a hemodynamic support in such a patient?
Thanks, Ashok. I think you mentioned that, this bifurcation, I think you have a choice of decalcifying either with IVL, which you have mentioned, with Rota, the standard burr, or with maybe orbital, which is another way. So I think the choice for me would be also Rota, good old-fashioned Rota, because the angle is very acute also, and it's a very huge left main going to the circ and the LAD. And what did you ask me?
Hemodynamic support. Do you want it to use a hemodynamic support for this patient?
I think KK has done a very good job on the right. So the EF looks a little bit quite satisfactory. I would have a support on standby, IAPB on standby, but not necessarily in.
Yeah.
Just get the groin prep.
Yeah, so the sheath maybe 5 French sheath on the other side if as a standby.
Yes, of course.
Fine. I'm coming to you now that all that's done, and you now have to send this. What technique would you follow? Remember, high bleeding risk patient?
Yeah, good. It's a good question. I think you will almost certainly have to stent the LAD also, and I would aim for a 2-stent strategy up front. technique of your choice, DK crush, cool out, I would leave that to the operator.
Good. And yes, go ahead, Richard.
Sorry, I think you asked a very important question about support. So besides the standard IPB that most of us are familiar with, I think we can consider Impala if people like you and elsewhere, Paul Ong or Hihua, they're used to Impala. I think Impala would not be out of place here, despite the fact that the EF is quite good, because this is a very important area. And this lady or man, very high risk, you know. He's got full house of everything, but carcinoma, got end-stage kidney disease, and everything else. And I think the calcium score must be in the thousands, you know, here, for what it's worth. Not that it's important to make us decide. So your question about support is very important.
Yeah, you're right, Richard.
If something should, you know, go not the way you want, we want the support to be really there or at least on standby. Thank you.
That's a great, just for everyone's understanding, in the United States, based on the scoring system of Washington, this would actually be fitting into a supported PCI with Impella. We are now based on our consensus statement, which was published in Asia Intervention, this would come into consider Impella. Heavily calcified left vein bifurcation in an elderly patient with anemia would come perhaps into consider Impella support. But now final, DAPT, and that's the, my last point. High bleeding risk patient has a bifurcation, 2-stent strategy, clearly in AF, NOACs, strategy of antiplatelet therapy in this 75-year-old elderly lady with cirrhosis.
Yeah, so I prefer the DAPT for more than 12 months, typically 12 months only. Now, I'm not using DAPT more than 12 months in any of the patients. It's considering the bleeding and...
Patients on NOACs.
Yeah?
Patient is on NOAC, AF.
Yeah. But still, I'm trying to start with the DAPT and looking at the bleeding complications like bruise or something like that. So I prefer to continue it. But if she's complaining of a bruise or some other bleeding complication, I have no hesitance to discontinue the aspirin.
Some others may vary in their approach in this patient, NOAC, high bleeding risk, cirrhosis, etc. Yes, aspirin definitely. Triple therapy would be longer than a month, but perhaps, I guess, no longer than 3 months is what I would think if the patient went fine and it was IVUS-guided bifurcation stenting. We are over to you.
All right, great, thanks, Ashu. I think the comments and remarks by everyone has been really helpful. We discussed this a little bit, and I wired the LED first, and because there is heavy calcium, I went ahead to just rotablate the LED first. Now, I have debated with myself whether I would do the circ first, but in this case, I was confident I could wire the circ, and I felt the circ was going to be more challenging. So I dealt with the LED first, and this is the picture after that. I think the circ is still there. So, now the LED has been fixed, and I just want to show the wiring of the circ. Now, all of you pointed out that rotablator is an option, but I think really what worries me is the extreme angulation of that circumflex. We were able to wire the circ, and here we are. The wire didn't go all the way down. I had to dilate the distal lesion first in order to put my rotor wire safely. And to do that, I had to use a balloon anchor in the LAD. So we did that first, and now we are ready with the rotablator. This is the rotablator right at the ostium there. And you can see that I've used a roto extra support wire. It gives me wire bias, that is true, and that is actually intentional. I need to deal with that hunk of calcium. So now I have in front of me the Rotor Pro, and this is really quite a streamlined device. I've chosen a 125 burr, and the only reason why I chose a 125 burr is because I really wanted to gently shave off that calcium. And the good thing about the Rotor Pro is that you have control of it on your hand, and you can see that there's a knob at the top, which allows me to activate the device. You can see my fluoro images. So I'm going to turn it on. I've set it at 150,000. It's a gentle movement forward. You can hear the deceleration. I'm gently ablating the lesion. Now, I should add that I'm always a bit nervous with end-stage renal failure patients who have calcified left main. So in her case, I put in the balloon pump just to give me some ease of mind. So I've done a run of about maybe, 20 seconds. Normally I would go longer, but as I said, I tend to be a bit anxious with these renal failure patients. Now, while I'm doing the rotablating, one of the things I just want to point out is that I gently don't try to rush it. As long as the hemos are stable, I will gently sandpaper the lesion away. And you can see that even with a 125 burr, it's not exactly traversing the lesion easily.
KK, just to interrupt you, you said that you rotablated the LAD beforehand, is it?
Yes, yes.
What burr size did you use?
175.
Did you do any imaging prior to rotablating the LAD?
No, I think that's a good point. I had contemplated doing it, but I think for me, the looking at the amount of calcium, which is on both sides of the vessel on multiple views, is highly probable. In fact, it is that the patient has a severe calcification. I will have to image later on for vessel sizing, but for now, I was quite comfortable to just rotablate without the IVUS.
So just for the understanding
now, of course,
KK?
Sorry, while the burr is going on, I will have difficulty hearing folks, pardon me.
Maybe you can ask Dr. Donny, for the circumflex, would you choose a bigger size, 1.5 burr instead of 1.25?
Yes, that's the question on my mind actually. If I have this kind of case, I will maybe put a bigger burr. So I will start with 1.5, and then KK already showed us how used to using wire bias beautifully. But I will choose bigger burr.
So KK, comment on the 1.5 versus a 1.25 burr. I think it's important to educate the audience around this aspect as to what was your choice for and what are your concerns using a larger burr right up front in this highly angulated circumflex.
Yeah, I think, to be honest, the both options are possible. I've chosen a 125 burr because I wanted the more slimmer profile, and I want to just ablate gently because of the jagged edge of that calcium nodule. I really worry about perforating the vessel and or tearing what they call it, transecting the wire. So it's out of excess of caution, I think, that I've chosen a 125 burr. But I think it's definitely not an unreasonable option to choose a 1.5 burr. So in this case, it's just because I'm a bit paranoid.
Javier,
can I make a...
yourself? Yeah, Javier had a point.
No, I think first of all, I think that for the young colleagues that are participating, is the technique of rotablation you are seeing here is very nice, very good. I mean, it's not trying to make excessive movements, it's go step by step. Now, the reason because I stopped using 125 burrs in this particular situation, very angulated lesions, is because the risk of entrapment is very high. So, or it is higher than normal. So typically with a 1.5, you will have less risk of entrapment.
Take a picture.
And since we are using orbital atherectomy, this is the type of lesions that is our first choice. Because with orbital atherectomy, first, you will not have the burr bias that you can see here. You can see that the burr is never touching the plaque, which is actually in the inner part of the curve. The second thing is that when you have orbital atherectomy and you're making backward cutting, remember that a rotablator does not perform backward cutting, then you selectively are ablating the inner curve, which is where the plaque is. And more importantly, you will never get trapped. You will never get entrapment because you can always make your way out by performing sanding of the plaque. So that's the reason why what we are doing now is for this type of lesions, we go either for IVL or for orbital atherectomy.
So you saw that gentle movement and not pushing because of the concerns of a 1.25 burr getting stuck. But I'm a proponent of a 1.25 burr adequately, especially on angulated side branches where perforation gets decreased. You'll see a grooving there just now as a 1.25 goes across the ostium of the right angle circumflex. And that grooving is quite obvious. And when you take a 1.5 burr, right at the ostium, the grooving becomes larger. It doesn't mean we don't use a 1.25 burr. I think my strategy is clearly 1.25 followed by a 1.5 because ostia will get well rotablated with a 1.25, but the disc beyond that is actually going to need a 1.5. So we had comments. You carry on, KK, while we have some discussion here from Fahim and Pratap. Brief comments there, please.
KK, this is Fahim. I just first a comment on what Javier said. Orbital, in theory, has some advantages here, but when you have a lesion this tight, you really need the front cutting aspect of rotablation, and orbital is most likely not going to be able to cross into this. My question to KK is that with the extra support wire that you've taken, would you not be concerned about the wire bias leading to guttering of the plaque, and especially with the 125, and that could lead to not only entrapment, but other issues. So I'm curious to hear your thoughts on why you use the extra support wire here.
You know, that's a good point, Fahim. We also discussed this a little bit. You can see that there is a trough. I would say that I kind of want that trough because of that nodule. I do intend to use IVL after this, as you know, as was mentioned. I can't remember who spoke. Was it Ashok who mentioned Roto and IVL? Now the other strategy of using a floppy wire, and I believe Boston is a nice new wire nowadays, is also possible, but it will ablate more in the center, but it might not create the ability to ablate that calcium nodule, which is what I seek. So we do have to, I mean, in this case, I thought that my goal being what it is to deal with that nodule. Now for this next part, I hope that helps with my thinking. Go ahead.
Actually, I have two comments. One is actually, in this case, my preference will be to do a rotablation to the circumflex first than the LAD, number one. Number two, if I could do imaging on the circumflex ostium, and if you see concentric calcium around in the proximal part, then I can go ahead with 1.5. If I don't see a concentric calcium, I should be very careful about taking 1.5 as the first choice, preferably to take a 1.25 and create an entry point correctly. Then as Dr. Ashok said, then you take a 1.5 will be a much better choice if you have a concentric calcium. Eccentric, chance of perforation, that is to be definitely thought in this case.
Very valid comment.
Okay, Mizuki.
So after this, are you planning to upsize your burr for circumflex, KK, or are you going to do imaging?
So I don't know whether you saw that there was a 1.5 burr, and I will image after this once I've changed out the wire, but first we'll walk it out with Dynaglide. You ready? So this is really nice. You know, the new Roto Pro is helpful in terms of having just being on the table. I can relax my right foot. And here, Dr. Muhammad here is nicely taking out the burr with Dynaglide on.
KK, can I just comment that you were not just relaxed on your left foot, you were relaxed on your left hand as well, which was in your pocket while you were doing it.
Right. Yeah, so I think you all saw the previous path. There is that trough, which I think, was it Fahim that nicely commented on. You know, for my rotor cases, I tend to have, you know, the usual rescue devices in the cath lab, and I think that's important because sometimes it's a bit unpredictable, and I remain extremely paranoid about such cases. So the wire has gone a little bit, you know, in a direction which I am not entirely happy with. We have to keep an eye on that. But I'm just going to put in my my favorite pull some more. BMW wire pull some more, sister.
You can see the wire bias to one side.
Yep. So we'll take, once we've gotten this Mizuki 1.7 French in, we will change out for BMW wire, and then we'll do some imaging. And I think in this case, I heard the discussion regarding OCT, and I was given that this is the left main, and I probably have to do a few things. Probably IVUS would be much better. Yeah, okay, good.
So I think, yes, the distal tip of the wire should always be under vision. I think most of rotablator perforations equally happen with the tip of the wire in a small branch, which gets forgotten while burring right in the proximal segments.
Dr. Seth, actually, what will be your choice of whether you go for the cutting balloon or an IVL, and what conditions you will go for a cutting balloon or versus IVL as the choice?
So that's a great question, and maybe I think I'm going to show this to Javier. Javier, this is obviously, and we all predict sitting here, that's going to show this heavy calcification, deep calcification. It's going to be followed by an IVL. All of us in our lab would clearly follow this up with an IVL. Osteal lesions, heavily calcified in the left main, are the nidus for restenosis, and we need the largest MSAs there, and that can only come if we do intravascular lithotripsy. But the point is, why not just balloon dilate and then do IVL? Obviously, imaging, but why not IVL? What is the data?
No, my question is cutting balloon versus IVL.
I'm even now coming to device synergy. I'm saying, what is the evidence for device synergy, which is where you're saying rota, cutting balloon, IVL. But I'm asking Javier, why not just balloon and IVL? What is the data for all that, what we've done till now? And I'm going to do later.
I think the data that I will say is more solid is that the larger the luminal area in the stent you get, the better the results in the long term. This is the incontestable evidence we have. All the other things, I mean, whether, IVL produces a deep injury in the vessel that triggers restenosis or blah, 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 this is something that we really don't know. I mean, this is something, it will be very difficult, I believe, to demonstrate, because the latest study I heard that is about rotablator-based versus high-pressure balloon-based, I don't remember the trial, came with a non-inferiority of a high-pressure balloon alone. So whatever means you have to obtain safe dilatation of the vessel with large stents, I think that this is the aim of the intervention nowadays.
So I think you can see the IVUS here. I'll let Dr. Mohammed here discuss.
So this is the IVUS from the mid circumflex. You can see there's actually circumferential calcium, which actually showed the some disruption from our rotablation. The size is actually large.
What I'm going to do is that I'm going to go ahead and do put a wire in the LED, and then I know I went through the IVUS very fast, so I'm going to let Dr. Mohammed here go through the IVUS with you at leisure while I wire the LED and do some ballooning work and the shock wave. Okay, so maybe we'll show the IVUS again, if you don't mind, Obi-Wan, and then maybe the panel can go through that and discuss together with Dr. Mohammed here.
Okay, let's start the IVUS run again. So mid-LED circumferential calcium, it looks like 1, 2, 3, almost like a 4 at the circ. Okay, so it's a large vessel distally. And then this is the tightest lesion at the proximal area. And then the left main, just here's the left main. So 1, 2, 3. So a very large left main. 1, 2, 3, 4, 5. Almost 5 to 6. So that's going to be our challenge on what sort of strategy and stent choices that we're going to choose, because we got to stand left main to the sub and left main to the LED. So something that can expand to 5, even 6 over.
Give me the...
sorry, Ido, can you show the frame, especially at the ostial left circumflex, because that is where the calcium is especially heavy. So we just want to see whether
give me a trio NC.
is any crack in the plot.
Can you go divers to the ostial sub? Yeah, so it's...
So you've actually got cracks in the calcium already, so maybe an NC balloon might be a good starting point rather than IVL.
Yeah, so you're right, Fahim. I am now just whipped out the trio NC just to see what it looks like. I think there will be salutary effects from the rotablator from all those deep cracks, but I just wonder whether we can optimize further with, because I don't want to be caught in a situation of regret, given the vessel of this size. But you're right, so that's why the next item going up is the trio NC. It might not even be big enough, but I didn't want to go berserk, right off the back.
KK,
yes.
your 1.5 burr as you go down the circumflex is not biased. It's biased internally at the ostia, but biased away from the huge calcium chunk as you went down the circumflex. I suspect you've got a huge chunk of calcification on
You're
the
right.
outer aspect. And while you may actually do dilate with a balloon, again, we're coming to the same facts. Does a balloon followed by a stent give you the best MSAs, or would
16.
it be an IVL followed by a stent?
20. Let's go up again. Yeah, right. I would actually. So it seems to be open nicely, but you're right. There is that tiny waist, and I'm going to go a bit deeper and see whether that waist is still there. Okay, but you know, the point you made is a good one, and
20.
I would frankly prefer to shockwave. And you can see there's
That's
still
the
that waist, yeah.
That's the waist I was talking
Yeah,
about.
there's still 20 hemispheres. So let's give me a 4-row IVL, please.
And that's the one which your rotablator burr would not have touched because it was the wire bias was outwards.
Right. Yeah, and I think that's the beauty of modern technology. We now have with us more than one ablative technology and a shockwave. Together, they form a powerful armamentarium for interventionalists and cardiologists.
Again, for the audience here and the younger gen, what he did was great. In fact, the balloon test perhaps is the most important test,
Give me REO
I would say, prior to understanding whether you need to. So if you didn't want to image,
Test
or you
me.
didn't, the imaging catheter wasn't going through, your balloon test is a great one. If you've got an
See the
optimal size
stories.
balloon, fully dilated, you're pretty good.
good.
And
Thanks,
if you're
Arya,
not fully
follow.
dilated, you're ready to do further work. So I think that's
Sylvester's
important at
following.
every step. Finally, prior to
60.
stent implantation, I believe not imaging, but the balloon test is the most important test prior to stent implantation.
I'd echo that, and I think the important thing that KK is showing is in two orthogonal views, you're seeing the balloon not expand. So you know that there's a problem and you have to go to the next step.
My doubt is actually he has used in 1.75 for the LAD. He used a 1.25 burr for the ostial circumflex. Why he did not take after the IVUS imaging? Why keeping the rota wire itself do an IVUS imaging and then take a 1.75 bar to create a better lumen area in the ostial circumflex and then go for the next interventional part?
You know, that's a really good question. I actually thought of it, and the reason is this. You look at this one fiber, it went in easily. So I wasn't sure whether a 175 would do it, and any further good. I've already knelt with that knuckle of calcium, and as you see on the IVUS, there's really deep cracks. But you're right. I mean, you know, I could have, but in this case, I felt confident that the goal had already been achieved, and I was worried about making a deeper trough and the risk of perforation. So it's a kind of, I guess in this case, it's a bit of a judgment call. I have in my hands now a 4-row, what you call it, shockwave. And it's going to go to the proximal. Now, I have to be careful here because the left main is of course, maybe affected the flow. So we'll just have to keep an eye on things.
No, when you take a shockwave, actually, what type of balloon you will take? What size of the balloon you take? You see a distal, a circumflex look like a 4 millimeter vessel.
Correct.
And,
so this is a
you should
4-row.
minimum 3.5 will you take? And if you take a 3.5 shockwave balloon, a 2.5 millimeter balloon passage
Flaring?
may not
wait,
be
wait, sorry.
giving
Down.
a chance that sometimes it will not cross.
Okay, that might go up here. Give me a 2.5 again. Okay, so this is 6 hemispheres.
Okay.
Okay, up, cool. So I wanted to go a bit distal, but there was some resistance, so I think I'll just blast this first. And I don't know whether y'all can see the fluoro screen, the distal segment of this vessel. Okay, okay, save that. Didn't allow me to go further, so I'm going to try now and see what I can do, but I might have to balloon anchor to go further. We're going to go up again, go to this is 4 millimeter balloon to answer your question. And we are at 6 hemispheres. I'm going to cine because I think it's hard to visualize. And you can really appreciate the nastiness of this waist. It's unpleasant, safe. Okay, go to one more blast. Huh?
Good on.
Okay, good.
Sometimes the body wire may help, KK.
You're right. Let me see whether I can blast this part more first and before I go buddy it. Okay, up. 6 hemispheres.
6.
The buddy wire, in our practice, we use a lot of the wiggle wire. It seems to help a lot to get stuff to
I finally found
cross
somebody
these
who's a
lesions.
fan of the wiggle like me. Safe. Okay, down.
So while you're firing the the pulses, could you also show the EKG and see
yes.
what's happening to that?
OB-Van, could you all do something about the EKG?
And those who want to get more experience with this IVL,
Collimate for me.
two things to understand. It's more difficult to push it. Once it's inflated, it's easier to pull it. So one tries to go as distally as possible and then come backwards
See.
rather than do proximally and push it forwards. It's a poor re-wrap.
Yep, go up again.
The second aspect is that you see these shock topics, as you will see. You just need to keep looking at that. Make sure that you're ready. There has been an occasional or rare or a single report of ventricular fibrillation related to that. R on T. Person may lose some of his pressures when those shock topics come, but otherwise usually inconsequential. But certainly keep looking at the monitor and be aware.
So this lesion is, go to 6 MSC, it's rather resistant, I must say. It's reducing my advances. Oh, it's slightly better now.
Yes, the reason for that is, of course, that you must remember that your emitters are not at the worst part of the eccentricity, as I would say.
Yep.
If you keep that in mind, 2, then 4, and 2, 6, and 4, perhaps your distal emitter is still before that unyielding part. And unless you get this further...
Yeah, I think I managed to get it a bit further here, as you see.
Yeah.
But really nasty piece of
there, you're
rock,
getting
I
it
must
better.
say.
But
it looks a bit better.
It's getting better.
Okay, wait, let me see first.
Again, that emphasis on why the emitters, the maximum propulsion or maximum force is at the emitters. And therefore, for unyielding or eccentric lesions or nodules, better to put the emitter at the worst point of the lesion.
Okay, good. So that's our last blast. I'm going to uncollimate a bit, please. Just release a bit of tension in the guide and make sure that my wires have not moved too much. And we'll, I think this patient has enough calcium to merit 2 shock waves, because I don't want a shock wave regret, So I'm just going to do it in this case. Another shock wave, please, Foro.
So you're given 80 pulses for the first one already?
Yes, I have. And if this doesn't deliver, I'm not going to use it at all. I'm going to do what both Hihua and Fahim had suggested, which is to use the wiggle to get additional support. Now, while we'll do this, I'm going to take a picture just to give everybody and myself a sense of where we are. But it looks like we've done some good there.
You have a nice lumen gain, but
Yes.
we can see the calcium is still quite thick.
Yeah.
But not adequate.
Not adequate, you're right.
No, actually, if it is not up and up, Dr. Ashok said, what will you the next choice? Whether will you take a rota higher size or you will take a shockwave balloon lower size? What will be the next choice?
Here, my choice is clearly going with another shock wave.
Okay.
And slightly further so that I know my emitters are at that worst point and delivering my next 80
Will you
pulses,
take a
because
lower-
a single balloon may not suffice for such heavy and beyond that, you ask me what I would do if it's still unyielding. It's ultra high pressure balloon. 3.5, not 4 ultra high pressure.
Okay.
One size less, but
After that
ability to go to
3.5,
40
shock wave to the
atmospheres,
LED.
because it'll become 3.9 at that time. And that's my next step prior to stent implantation.
My question is OPN balloon or a normal balloon?
OPN, ultra high pressure at 40 atmospheres.
Ashok and Javier, can I ask you, would you consider using orbital now at this stage, assuming there's no obvious dissection and you've still got a waist with, let's say, the next shock wave, would you then go with orbital?
It's a very good point. No, I certainly will not use at this point orbital, because you should not use it when you have dissections. It has much more penetration than rotational atherectomy. What we've been doing, I think that we've been the first center using the new generation of shockwave that delivers 120 pulses, which are very useful for this, and it will be soon available. Very good results. This is something that is very useful. And the other thing that I think is convenient that we always do is when we inflate the shockwave balloon, we perform angiography and we move the Z arm to see if the balloon is fully inflated, because what happens in many occasions here is that you have recoil immediately after you deflate the balloon, which of course is because you have a lot of plaque, and you may have a false sense of what you have achieved. You understand what I mean? So that's filming the balloon and performing a bit of rotational angiography, just moving your C arm, is something that in many occasions is very helpful.
Find me a 3.5 angioscope. But you can, you guys can appreciate that narrow, ugly looking up. It's still there.
It's still not opened up.
Yeah, it's sort of very resistant to my arguments.
Sorry, can you? That's now on your proximal emitter. So the emitters are, the proximal is 2 millimeters from the proximal balloon marker, and then there's a 6 millimeter gap between the two emitters, and then there's a final 4 millimeter gap, and then there's the balloon marker. So putting the balloon centrally is not a great idea. Putting the balloon eccentrically to the tightest part of the lesion gets you the maximum.
I did this, so you can see from the earlier pictures that we did that, and I adjusted it just for, maximal effect.
You're showing it tremendously well, KK. This is a great case for learning for all of us.
So I heard you're asking for an angioscope, is it, KK?
Yeah, I'm scared of the OPN.
How about using the Wolverine? Because, I mean, Wolverine is a bit shorter. I think angioscope sometimes can be a bit more difficult to deliver.
Yeah, I mean, that's another good option. It's just that, I've had good experience with both, and
3.5 into 6 Wolverine balloon will be very good because it's a shorter balloon and it is easily to trackable, and then it is.
Well, the angioscope is 10. It's also pretty deliverable. What do we have? Okay, I'm down to my last blast. Okay, go up again.
6.
Would you take a cine, please? Because it'll just reveal to us.
It's really very resistant.
Not at all opened up.
Yeah, man. Okay,
there are two choices. You can take a Rotabar 1.75 also.
I want to say that this is quite a piece of rock.
Yes, it is a piece of rock.
That is what I said.
Let's see what happens with the angioscope.
I mean, of course, you could consider also, as an intermediate step to use a cutting balloon now. I mean, you never know. Sometimes this synergy between different plaque preparation techniques helps. But the message is that you have to have patience. I think that this is a very important message for the young colleagues in this particular subset. Don't hurry.
Yeah.
So I want to maybe chime in to say that today's case is meant to illustrate the management of that calcium. The rest of the stuff, the bifurcation stuff, I think you all probably will see in another part of Sing Live. So I think that's what we're going to try to show. Okay, let's go up here.
That's correct, KK. I think this is
20.
one of those resistant calcification.
20.
And by the way, I'm not if I was going to use an angioscope, I would actually be safer off with an OPN.
Really?
It's opened up.
The reason, no, it's in the other view that it actually shows the eccentricity. The reason is that we're just too scared of it doesn't expand that much as long as you know the expansion characteristics of the OPN. And to tell you frankly, I find it a safer non-compliant balloon than anything else at the moment.
Down.
Okay, I mean, that's good to know, I think that's definitely a good option. I might have to go to it. But this is proving to be a real, argumentative piece of calcium 24. So how many of you would recommend I use OPN? Or, some of us might say that, this is good enough. Come on, I mean, perfection is the enemy of good, right? So would you all be happy with this? Let's go up again, 20.
It has improved a lot. It has really, really improved a lot.
I mean, how many of you would not see me cry? Like 20 again, up again.
Maybe you can do an IVIS, KK, to see the MLA and the
So, also, what sort of pressures are you at?
24. We're at 24 atmospheres.
And what is the balloon size at?
3.5.
Yeah, 3.5 at 24 atmospheres. Angiosculpt becomes 3.9.
Yeah, so it's pretty aggressive already. Okay, down. I might, say that this is. Let's take a picture. So can I poll the expert panel and see how many of you would ask me to, let's make sure we all have, we have done a very substantial effort in managing that calcium load. Maybe this is as best as we can. Or how many of you asked me to go for OPN? Give me the shockwave for
the way I assess this, KK, is that if I've got a residuum in both views, then I'm not happy. If I've got residual in one view, then I know that I'm expanding in the other view. Then I know I'll have good MSAs. So I don't chase eccentric lesions unless I see residual stenosis on the balloon in both views. And if I do, then I would chase it completely.
And if you don't get a proper expansion, will you leave it by the circumflex as without any stent and stent only to LMCA to LED is an option with a deb in the circumflex ostium? And my question is actually, is it better to put by putting a stent than creating a stent thrombosis? And that is it, which is the better choice?
That's a very important question.
Provocative, huh?
Undilated lesion, never stent. But I wouldn't call this undilated at the moment. I think you'll get pretty large MSAs, even with this residual stenosis. We'd like to get this residual stenosis away because it's in both views. But had it been in one view, I would be assuring you that we'd have large MSAs.
KK, at this point, I would consider IVUSing it. And if you have good luminal gain in that area that's relatively underexpanded, I think I would accept it and just go ahead and stand.
Yeah. I must say I'm intrigued by the idea of just using a drug-coated balloon for the circ ostium.
I think that would be quite an attractive option, KK.
When you look to the size that you obtain when you are inflating the angiosculpt balloon and the lumen, and again, as Ashok has said, we are seeing here the effect of a very eccentric calcific stenosis. You can see that there is an element of recoil as well. So, I think that I will do is I will choose a stent that has a strong radial support, like perhaps a Megatron stent, perhaps. And I believe that the minimum stent area that you are going to have there is going to be more than acceptable at this particular point. So it's a very good example that that you have to really improve things a lot. Perhaps it's not cosmetically speaking, a perfect dilatation of a calcific plaque, but you also have to balance the risks, like you did before, of thinking of going an OPM balloon and perhaps risking having a perforation.
Yeah.
I'm still a proponent of OP in this situation, always. Always. I do my best not to leave a residual stenosis behind because it's a safe balloon.
Okay.
I think we just worry about the pressure number, but it's a safer NC balloon than the other NC balloons that we use and go up to 28 atmospheres often.
Ashok, which size of the OPN would you use?
3.5. 3.5, not a 4. So that keeps you safe.
A 0.5 less than the vessel size will be ideal in this situation.
All right.
6. Sorry, I missed that.
In fact, it's such a lovely case that we missed the fact that we exceeded the time. Did you all realize that?
Okay, I tell you what, why don't you go to the lecture and I'll just continue chugging away.
Correct.
Okay,
and that was great demonstration, great learning. I mean, for all of us sitting here, you saw the number of different strategies that we were thinking through and we have in our mind, including just a drug-coated balloon and nothing more than that. So I think that those are great suggestions, and I think, thank you. We have 3 minutes to go for the next session, but hopefully we'll have some feedback from the cath lab and how KK is doing, and I'm sure everybody's just keen to actually get a last glimpse of that case. KK, can you hear us?
The ultrasound still shows a very thick calcium, and I think that it is really, if you look at the IVUS, I'm going to let Mohammed go through, Sister Hami, and you can appreciate that, that calcium is literally like all over the place. So maybe, Mohammed, you want to go through that?
Yeah, so actually we actually went out with a 3.5 OPN and high pressure. In fact, it burst. And then we went through let's do the IVUS run again. Yeah, so the IVUS still showed that at the ostial circumflex, still suboptimal, not fully expanded with the circumferential calcium. So we don't feel it's optimal to do any stenting at this time. And we've actually opted to go with a bigger burr. So now we're going in with the 175.
Yeah, so I can't remember who mentioned it, but I think you are right. We should have done the 175, huh? And there's resistance at this spot. I have covered stents on standby. And Auntie, so 放下来.
Great. So I think this has been a great learning. A number of strategies were put forth to you, and they were all tremendous. It's how you apply these device synergy to, like we said, to get your best lumens is what matters. And you're painstakingly doing that without putting in a stent. And I think that's the learning. Have the lesion adequately prepared prior to a stent. The moment you put in a stent, you put your foot into the biggest swamp that you will ever experience. So thank you, KK. Great learning.
Thanks,
great
everyone.
case. Congratulations
to
you and your team.
Okay, thank you. So we're going to close today's session, and I would like to thank our fellow panelists, and we'll move on to the next live case. Thank you very much.